Okay, so let's go and talk a little bit more about evaluation for meniscal transplants. And that is looking at articular cartilage changes. This is all stuff that is pretty straightforward. So the other thing you need to evaluate, and here we can see that there's complete loss of the articular cartilage, subchondral eburnation, subchondral cystic changes, which we're all familiar with. We also see large marginal osteophytes. So this is grade 4 chondromalacia, and you need to follow that over time. And here's we can see a little bit of progression to further subchondral cystic disease uh, in this time interval of a few months. Now, we were hoping that by putting in meniscal allografts in patients who have pre-existing degenerative disease, that might slow down the degenerative disease and decrease the need to go on to a total knee, but there's no proof that that's the case. And then look for subchondral changes and all the bone marrow edema that you're all familiar with. So those are all the things that need to be described in the report when you do meniscal transplants. And here we can just see another example of a meniscal transplant put in. Here we can see the posterior horn, anterior horn, 10-2308. Looks like it's pretty good position. The anterior horn's a little bit anteriorly positioned, but that's generally considered acceptable. Hard to see it here. This is the edge of the transplant. This is the residual posterior horn that's left in to stabilize that posterior horn. So this is in 2007. And then the patient came back. This is 2008. The body looks in pretty good shape. A little extrusion here. And now a recent study came out saying that up to 3 millimeters doesn't seem to increase the risk for the development of degenerative disease with 5-year follow-up. And here we can see this looks pretty good. This is a year out, and the meniscus, the transplant is in good shape. Here's another year later. We're getting some volume loss, a little bit more extrusion of the body here, but still the posterior horn and anterior horn look like they're in pretty stable position. In this particular case, again, this is the native peripheral meniscus, and this is the graft. So that was a successful transplant. So there's a lot of stuff we don't know. Natasha's been involved in a study looking at 250 some odd cases that we've done over the last 20 years and presented some of this at the AAOS last year, but there's still a lot of information that we don't know at this time. So let's go on to other areas here. Tayson, what do you think of this case?
So we have a coronal and sagittal PD fat set. It looks like there's some extrusion of that graft, right?
Well, I don't think this is a graft. Here we can see on the lateral side, we see that there's a complete tear of the body of the meniscus here. Here
Yeah.
we can see the tear there, a little horizontal component as well. If we go to the axial images, we can see that it's a complete radial tear with separation of the anterior and posterior horns here. So this is a very poor prognosis, basically the same as not having a meniscus in there. So this is kind of a meniscal fracture. So what's happened here? Same patient. So before this was 6/25/13, and now we're at 7/25/13, so we're a month out.
So it looks like there's a tunnel in the
Mhm.
lateral tibial plateau there, so I'm assuming they anchored it back
And there's
down.
some
Yeah.
stuff going on here, a little stuff going on there. And then if you remember before, there was no body out here.
Yeah.
And we can see that there's been some kind of surgery right in the area where there was that big defect. So this is at the arthroscopy. Here's that fractured meniscus. You can see all the way through it here, just like you would expect from the MR. So they then took a segment of meniscus. So this is a segmental graft where they took a piece of meniscus, trimmed the meniscus, and put it in, which you can see it being sutured in here. And this is called a segmental transplant. Uh, I don't think a lot of these have been successful because I haven't seen very many done, which makes me concerned about the success of these, but it is a technique which we've seen a little bit of. Okay. Roberto.
Okay, so we have a 26-year-old post-op with knee pain, two coronals of the knee. Looks like there's a tunnel in the lateral femoral
So
condyle.
what is this tunnel?
That's, that's a good question. I guess you wouldn't really put the graph there on that side. So it's like some.
Sort of the non-articular portion. It's not where you have it in the menisci.
Mhm.
Okay, so when you see this is actually, time of surgery, they go in and extract bone marrow. Because a lot of people believe that bone marrow actually has active ingredients in it, both cells and chemicals, which can actually be pro-inflammatory and actually accelerate healing process. So some people, when they do arthroscopic surgery, like to put in PRP. Some people like to put in uh, uh, stem cells. And some people believe that just doing a bone marrow aspirate and putting into the joint space improves the overall healing, especially if you're doing some sort of a repair process. I don't think the data is overwhelming for this, but there are a lot of people who believe that there are pro-healing components of bone marrow aspirate that can actually help the healing process. So when you see that, that's what that is. So what else do you see here?
Let's see. So we got a sagittal and axial of the knee. Let's see.
See a lot of metal artifacts here.
Yeah.
And this was actually another segment of transplant. A lot of the techniques don't use as much metal, so we can actually see the transplant, and it looks more like a normal tissue. And in this case, there was a lot of artifact associated with the technique. Okay, Elior.
Okay, 46-year-old female arthroscopy with ACL revision and lateral meniscal transplant, pulseless after surgery. Yeah, we see these sagittal views. You see a bony fragment of the tibial plateau there with some edema in it.
This?
Yes. There's also edema posteriorly. This pulseless makes me want to look at the vessels. Yeah. I mean, do we get a loss of the flow void in the popliteal artery or?
Yeah, this is a funny little structure here, nice structure there.
Yeah.
Go to the axial images.
Mm,
So
yeah.
here are the veins,
Yeah.
there's the artery.
Yeah, okay. So loss of signal there. Okay. Was it maybe transected during the surgery or? Yeah.
Yeah, so they entered the popliteal artery and at the time of surgery and got a clot in the artery.
Okay.
Right. So, okay. So now we can talk a little bit about the meniscal ligaments. There are the meniscofemoral ligaments, which are Risberg's and Humphrey. There's transverse ligaments, meniscal-meniscal ligaments, and the anterior iliotibial band meniscal ligament, which has a bunch of other names, some of which we've already talked about in previous lectures. So here's Risberg's ligament, which I'm sure everybody's heard of. It goes from the posterior horn of the lateral meniscus to the lateral aspect of the medial femoral condyle and the notch of the knee here. Risberg's ligament starts with a W, so it's low in the alphabet, so it's behind the PCL. Some people like it this way. So this is Risberg's ligament, which we see here, and that's normal. It's not really even a variant; it's just normal anatomy, but it's seen on anywhere from 20 to 60% of individuals, depending upon what group you look at. So I think you're all familiar with that. We've already talked a little bit about it. So here we can see a Risberg's ligament behind the PCL in the sagittal images. We can follow it down to where it attaches to the lateral meniscus. And as we've talked a little bit about before, the lateral meniscus should actually attach to the tibia. There is a variant called a Risberg variant where the posterior horn of the lateral meniscus does not attach to the tibia, but only attaches to Risberg ligament, like we're seeing here. And so some people believe this is a congenital variant. I'm not sure how well that's been studied in fetuses or newborns. The other possibility is that this is actually due to a posterior root tear of the lateral meniscus, and you're just left with Risberg's attachment. My gut feeling is that both may be correct, but my guess is root tears are much more common than a congenital variant. But I don't think we have good data to prove that. Okay, Jason, what do you think of this case?
All right, so it looks like we have a PD sagittal of the
Yep.
knee at the level where I expect to see the ACL.
Okay, there's the ACL right here.
Yeah.
There's the PCL.
PCL, and then there's a ligament of Risberg.
Risberg's here.
Yeah.
Okay, there. If we go to the coronal images, that's what it looks like.
So is it I mean it looks like it's balled up, so is it torn from its
So that's a loose body. So this patient doesn't have a Risberg's ligament. They just have a loose body that's
right where you
behind.
expect it to
So
be.
you have to make sure you follow it to make sure it's a ligament and not a loose body.
I see.
A little pitfall there. Okay, and then Humphrey's ligament is the same thing, but it goes anterior to the PCL. H is earlier in the alphabet, so it's in front of the PCL. And there we can see it there. And okay, wait a second here. That's Humphrey's ligament. Oops, this is a new case. Robert.
So we have a coronal of the knee. It looks like there's some marrow edema in that lateral femoral condo, and then I guess so.
They have to be concerned about an ACL.
Right, right.
Okay, and then that could be the meniscotibial attachment, but we're really a little bit too anterior for the meniscotibial attachment there.
Okay,
And then here's what the sagittal would look like.
gotcha. Looks like that ACL is torn.
So here's the torn ACL. So that was actually an inferior displaced ACL with the tear. And here's Humphrey's ligament right here. The PCL behind over there. And then if we go over here, we can see that there's an injury to the posterior horn of the lateral meniscus, and here we're actually seeing a little bit of a complex tear of the posterior horn in the periphery there. We can follow that all the way out. And so this was one of the complications you get when you get a displacement like what you have with ACL tears, is that the Humphreys and Risberg's ligament can then pull on the attachment to the meniscus, and you can get a rip there called Risberg's rip, where the ligament rips off its attachment to the meniscus. Okay. Okay, and then here's a transverse ligament. Okay. Okay, so this goes between the anterior horn of the lateral meniscus and the anterior horn of the medial meniscus. We've already talked about this concerning one of the early cases that we did with MR, and here we can see here's the medial side. There's the transverse ligament coming off the medial meniscus. This is right in the middle, but between in the notch of the knee, and we can see that it then can come over and attach to the anterior horn of the lateral meniscus. And as I believe I showed before, occasionally you'll get a cut here where you'll get very close to where the anterior transverse ligament actually attaches to the anterior horn, but there's still a little bit of fat separating the two there. And if you just have to be careful not to call that a tear. I don't think anybody does that anymore, but I already told you about in the very early days we had that issue. This is what it looks like when that occurs, and you just have to make sure you follow this across to make sure it's a transverse ligament and not call this an anterior horn tear. And there you can see it. And then if you follow it across, you can see it goes all the way across to the other side. So that's and you can occasionally see this on the medial side, but not very often, where it could look like a tear. So just be aware of the pitfall of the transverse ligament. So here's the transverse ligament is up there, and then we also have a ligament called the meniscal-meniscal ligament. It's not this big; it's usually very small. It goes from the anterior horn of the medial meniscus to the posterior horn of the lateral meniscus, across the notch of the knee between the ACL and PCL. Here's just an axial image from the literature showing that transverse meniscal ligament here. And it can look, sometimes people mistake these for loose bodies. We can see back here, or even a partial tear of the anterior cruciate ligament, because they can fall down here in the notch of the knee. But this is considered a normal variant. There we can see it. We can follow it all the way across the notch of the knee to its attachment to the other side. Okay, let's see. Elior, what's going on here?
Okay, so sagittal view. So I'm just seeing some circular dark signal.
This thing right here.
Yeah.
So we see that is. So what is that? So what would you want to do to evaluate that?
See if I can follow it. See if it's a normal attachment. Yeah.
Here's the axial image right through that area.
It looks like it could be that menisco-meniscal.
So this is the meniscal ligament. And so you just have to be aware of this, because sometimes these will be called loose bodies if you just look at them in sagittal images, if you don't follow them all the way from one side to the other. So it's another potential pitfall of the intrameniscal ligament. Okay. Jason, what do you think of this?
Injury versus variant. Okay, so we have a fluid-sensitive fat SAT sequence of the knee and sagittal view at the level of the ACL and PCL.
Okay.
PCL looks intact. Looks like there could be a ligament of Humphrey there. But what you're talking about is these two. Yeah. So that. I mean, I guess it could be the meniscal ligament.
Well, I think we talked about this ligament earlier. It's not the meniscal. It goes from the bone, goes from the femur down here.
Yeah,
in the anterior part
like
of the
meniscotibial
notch.
ligament.
And if you look at here, now this could be we'll talk about it when we get to the ligaments. There are two bands to the ACL, anteromedial and posterior lateral. These could be the two bands if we look at it just here. But here's another case like this, same sort of thing. But here, if you see this, you can see this more clearly, where the distal end goes to a structure that's not really the tibia. And if you follow this over, it actually goes to the anterior horn of the medial meniscus.
So it's the menisco-femoral?
So
it's the one that comes across, yeah.
So this is called the anomalous insertion
Oh,
of the
yeah,
medial
yeah.
meniscus.
That's right.
But it has a bunch of other names that we talked about before. The main thing is just to be aware that occasionally you can get a normal variant that can parallel the anterior margin of the ACL, but it goes to the anterior horn of the medial meniscus, and that's a normal variant.
Okay.
Anomalous insertion of the medial meniscus. I don't like this term. I'm blocking the other terms that I like better. That's terrible. Don't get old. I guess the alternative is worse, though.
We have a 15-year-old male with chronic knee pain, rule out meniscal tear. We have a axial and sagittal of the knee. Trying to follow the ACL. Don't really see it anteriorly that.
It's this. What's this?
Could it be that same anomalous?
All the way down. Here's the ACL insertion. Here's this thing's insertion. And it comes down here, and see, it's it's deviating over to the medial side of the knee, whereas the ACL stays more on the lateral side of the notch. And if you follow it, you follow all the way down, and it actually goes into the anterior horn of the medial meniscus. So, oh good, I think I'm going to have the other name for this time. So this is also can be called the anteromedial meniscofemoral ligament. The bottom line is you can, if you're good at names, that's great. If you're like me, just remember that this can be a normal variant. And if you need to put the name in the report, you can look it up. But this is the anteromedial meniscofemoral ligament, which is the term I prefer rather than anomalous insertion of the anterior horn of the medial meniscus. So if you look at these, you see them about 1% of the anterior lesion. Oh, some people believe that this particular variant of anatomy actually abnormally tethers the anterior horn of the meniscus and can lead to increased risks of injuries to the meniscus. But I think that this is still somewhat controversial. But this is another example of where it kind of comes down showing what it looks like pathologically. And this, I'm sorry, this is a different lesion. I'm sorry about this. This is another lesion. There's another lesion to look at, which is the anterior iliotibial band meniscal ligament. It goes from the distal end of the iliotibial band, which is on the lateral side, and it connects that band with the meniscus. So it's one of the many insertions of the distal iliotibial band. We'll talk about the two main ones later. And what they found is that you rarely have a lesion in the anterior horn of the lateral meniscus if you do not have this ligament. If you have the ligament, there's a much higher risk of injury, which is thought that this band can produce edema in Hoffa's fat pad due to kind of impingement upon the fat, as well as increased risk for lateral meniscal tears. These are rarely diagnosed on MR. They really occur from the iliotibial band, and you get a dark structure that going from the distal iliotibial band to the anterior horn of the meniscus. This is what it looks like in the kind of the arthroscopic visualization on MR. It's really a band coming out here that goes between the iliotibial band and the anterior horn of the lateral meniscus. And here you can see it coming down here and coming from the iliotibial band. Okay. So one of the things that we commonly see with degenerative tears of the menisci, here we can see a degenerative tear. This is an old study, obviously, and we can see here the meniscal tear, and then this is commonly associated with edema in the subchondral bone. We already talked about that. Probably the reason why a bone scan study from the late 1980s showed that it had a high correlation with meniscal tears because you get abnormal rubbing of the articular cartilage and subchondral bone when you have a meniscal tear, which can lead to this subchondral edema. So you'll see that pretty commonly, and that's bony reaction. And this is what it looks like on a bone scan. So you don't actually see the tear of the meniscus; you see the secondary subchondral bone reaction due to the meniscal tear. Okay, who's next? Okay, Elior, what do you think of this case?
Okay, so we've got coronal views here. I'm looking at the.
Let me show you. Here's a sagittal projection.
Okay, so. Okay, yeah, we're looking at the lateral meniscus. There's edema. There's
Here's the
some.
lateral meniscus.
Okay, the other lateral.
Go with lateral.
The,
So this is the medial collateral ligament.
uh,
So we have a meniscal tear, right?
yeah.
So the question really here is, what's the history? And the history here is that this was a sled dog that had a limp, 7-year-old sled dog
Okay.
who had a limp up in Alaska. And so they did an MR scan on the sled dog, and this is called the stifle of a sled dog, and they had a meniscal tear. Actually, when I was in Santa Barbara, we did a study from there's a famous horse hospital over the hill in the San Ynez Valley, and we did a study on horse stifle cadavers when I was there on the MR scan early on. Okay, well, why don't we stop here, and we'll move on to ligaments of the knee. Next time. Just let me stop.
So, Thursday? Or are you gonna, you're not gonna do lecture tomorrow?